Great. Well, thanks for coming out this morning, and I will try to keep to time, but I'll only try. First, I'm a medical doctor, so I got to start with my conflicts of interest. I have just a few. But suffice it to say, I've started a couple of companies. I consult for a bunch of companies. You might not want to believe another word I say for the next 30 minutes. I wouldn't blame you. But I'm most proud of the bottom right. Those are all the companies started by my students. More than half my graduate students now start companies, even if they go into academia, and they do it with the most amazing platform in the world. It's simply data. And it's often big data, and it's often open big data. So I'm going to show you how they do it. I'm going to show you how I do it, and maybe I'll convince you this is the most amazing time to be in biomedical innovation and entrepreneurship. It's no mystery if you pick up any magazine or journal today, people are talking about data and big data, and we're drowning in data. The Economist is the best one, right? You got this guy collecting ones and zeros with the umbrella. That's when they announced the humans were generating 2 zettabytes of data a couple years ago. And then more recently is the Economist saying, the world's most valuable resource is data, right? And so the saying from them now is data is the new oil. I prefer to think of it as data as the new soil. Right? You use that to plant seeds, right? It's not grabby, I'm having data, you can't, right? Most of the time we can all get to the same data. It's just what are we actually going to do with it? That's the harder problem here. So just a level set, folks, we're obviously using data to teach computers, right? And we have these terms, artificial intelligence, machine learning, deep learning, and just a kind of really basic level setting here. AI is part of the grander of the terms. We're trying to teach computers with, to do things that we love to do as humans, right? It could be driving cars, translating languages, that's AI. Machine learning is one way to teach computers using data. So you might look at me and say, well, of course you're going to teach computers using data. How else would you teach them? We used to teach them with rules, right? We used to ask experts, what would you do here? What would you do there? Gather the rules and then teach the computer. It turns out it's much better to see what people do rather than asking them what they would do, right? I mean, you can actually get the data of what experts do, not ask them what they think they would do. So that's using data. And then deep learning is a more recent term, but actually technology goes back a while. And deep learning is machine learning where the computer architecture crudely resembles layers of a brain, okay, but really crudely there. So those are those 3 terms. AI is probably the broader one, and deep learning is the most narrow one there. And these are software tools you download often for free off the internet and put into your software, right? There's no wizard behind the curtain here. These are just software toolkits. So I want to make sure we demystify that. And you can actually buy dummies books on all these on Amazon for like $19. It's Amazon Prime. So, I mean, literally it's at that level. It's software tools. Now, AI has been around in medicine for a long time. I mean, you go back to early 70s, even papers back in the late 60s, medicine and the computer, the promise and problems of change. People were forecasting a lot of future goodness and a lot of badness for decades, actually, from AI and computers and medicine. So but why is it back again? Because we now have much more data, right? Back then we didn't have a lot of genomics data. We certainly didn't have electronic medical records, which we'll talk about. And the problems are still out there. How do you care for populations? How do you discover new drugs? How do you tell the future for a patient? The problems are still out. And then the hardware has gotten much better. We have a lot of computer hardware from the gaming industry. Those video boards that gamers love, you can also use to teach computers. So that's why AI is back again in medicine. And boy, is it back. Just in the last 18 months, we've had at least 6 products or services approved by the FDA that have anything to do with AI. These are actually FDA approved. I think the first one is at the top there, January 2017. I mean, this is not that long ago. Arteris has, it's actually cloud-based, so you don't even install the computer. It's running somewhere else to help interpret cardiac images. Viz AI has one for triaging stroke. IDX has one for retinopathy. You take pictures of the back of the eye, you can tell if they have diabetic retinopathy or not. And there's at least 3 more, and I think there's a couple more, at least one every quarter now. So it's certainly a big time to get these types of tools out there. These are not going to get rid of doctors. We're not going to lay off doctors. We can discuss that over in the discussion session. But the doctors of the future are going to be powered by these tools, right? So the narrative you need to realize is it's not doctors versus computers. It's doctors with computers versus doctors without computers, okay? That's the narrative here, okay? Right? We're superpowers for docs that they just couldn't do before, predicting the future, things like that. All right, so of all this data, the data I love the most are electronic health records. Have you heard of EHRs? Boy, I'm sure this audience has. And you know we're spending billions on these systems, right? So here are just three, just to pick three neutral ones in some ways. Just to illustrate the price tag. So Sutter at the top spends $1 billion on their electronic health record system. Partners, which is Mass General and Brigham, and Boston starts with $1.2 billion, it's gone up since then, on their electronic health record system, and then Kaiser spends $4 billion on their electronic health record system. Amazingly, they all bought the same system, Epic, okay? So it ranges from $1 billion to $4 billion, right? Can you imagine, the sales process for something like that, right? It also helps to have your reporters writing the stories as friends, right? So Sutter spends $1 billion, it's written up as a boondoggle, and then Kaiser spends $4 billion, it's like they placed a bet and they won, right? So it helps have your friends writing the stories here. But the narrative here that I want to make sure you get is we as the United States are spending hundreds of billions of dollars putting these systems into place and rounding error close to zero using any of this data, right? And so what I want to try to convince you is this is now the most expensive data in America. We're paying doctors to type all this stuff in. It will be a national tragedy if we don't figure out how to use this data to improve the healthcare practice in the country, right? Every aspect needs to improve with this data, like every other industry does with their data, right? But we have basically not invested at all. Boy, if I need to innovate, if I wanted to disrupt, you know where I would be going, right? Because no one's there. It's all greenfield still. All right, so what can we do with data at the University of California? So you're sitting at the UC Irvine campus, but just to reintroduce UC, the way I think about it, UC is enormous, right? 10 campuses, of which 6 have medical schools, 3 national labs, 200,000 employees, that number will come up again. We're one of the larger employers in the United States. It turns out, 250,000 students a year. We train half the medical students and residents in California, $12 billion in clinical operating revenue. So just to kind of be coy for a second, if we just put that on the Fortune 500, 12 billion would put us around number 240, just under Toys R Us, which is probably telling.
It's not where they ended.
We shouldn't stick around at that part of the Fortune 500, I think, if you know what I mean. 5,000 faculty physicians get a paycheck from us, but actually 100,000 doctors see our patients, right? All the community docs around on our patients. We literally have orders from 100,000 docs. And we're not just random centers, 2 of them are top 10, but all 5 of the major ones. Riverside is tiny, they're brand new, but they're obviously one of the 6. The other 5 all have NCI comprehensive cancer centers and clinical translational science awards. So they're the best of the best here, right? So what are we doing is now, instead of each campus, or in addition to each campus operating in their own, like UC Irvine, UCLA, UCSF, that we now have this construct called UC Health that can oversee all of those. And it's a new construct, right? It's a business reason. There's a business reason to put this together because at some point our aspiration, 10 years from now, okay, so this is a real long-range aspiration, is that we should have a single accountable care organization for the entire University of California. That is called UC Health. Now, we're partnering with the United Health Group to actually learn how to take on risk and all of those things, right? And, like any relationship with a provider and a payer, these are love-hate things, right? So, but we don't know how to do this, right? Manage populations, take on risks, so you have to learn somewhere. And it's a 10-year aspiration, so don't go trying to figure out how to sign up for this today, right? I mean, it's a theoretical construct. But the minute you've made a business decision like that, you got to start to share the data, right? Because you start to look at practice variation. We take care of patients this way, you take care of them that way. That's kind of weird, right? Which of these is the right way to take care of a UC patient? And the best way to get there is to put all that data into one place. I wouldn't be an IT guy if I didn't know how to make boxes point to boxes. So here's the one slide that actually shows this, right? So here are the 6 silos, and silos are a nasty term nowadays anyway, all pointing to one new silo. But you can see UCSF, UCLA, Irvine, Davis, San Diego, and Riverside here. And all that data comes into one place. So where are we now? This is done. We actually have this working. And the number we love to tout is 15 million patients, right? So the University of California has cared for 15 million patients in the last 15 years. And if you do the math, that's 5% of the US population, right? It's a stunning number if you think about it. 5% of the US population has been cared for by us in the last 15 years. If you look at the modern era when when UCLA, UCSF put in Epic, it's about 5 million patients, 100 million encounters. Every time you call one of our doctors or nurses, that phone call is even documented in Epic, right? I mean, forget about admit notes and discharge notes, even every phone call. Think about just training, a chatbot with just the phone call data we have in there, right? You can just see how much data could feed innovation. The number I like is 250 million medications we've ordered, right? We've ordered 250 million medications. Everything from Tylenol to CAR T cells is an Epic now, right? We've ordered CAR T cells, it's an Epic. And we got Tylenol, right? Everything under the sun in medicine has been ordered now by us. Wouldn't it be useful to see if this stuff works actually on patients, right? That would be interesting, right? And got harmonization dashboards and all this. This is proof it's there, geocoding of every patient in this part of the country, UCSF, UC Davis, LA, Irvine, San Diego, and Riverside is there. Is it counting down or up? Oh, still got even. It's not plenty of time. Riverside's tiny. They're in red. You can't even see the dot there. This, by the way, is Las Vegas, right? Of course we see patients in Las Vegas. The Hawaiian Islands are covered with our colors. If you're sick in this part of the country, you come to UC when you're sick, okay? We have all the dots to kind of prove it there. And race and ethnicity, I mean, you got the diversity of the world in California and the diversity of California at the University of California. We see all comers here. This is another kind of proof element here. Just take one blood test, LDL. Some of you on the older side, you know you get your lipids checked. I'm technically a pediatrician, so I didn't really used to order this test that much, but LDL is supposed to be under 200. Okay, that's great. We have 1 million of them under 200, and not so good, we have 1 million of them over 200, okay? I hope these folks are on statins, but now I can go check if they're on statins, right? Because that's population management in just one slide here, right? We can see there's some badness here. Let's go see if we're making sure we're fixing that kind of thing. And we can do deep learning with this, and we partnered with a lot of different companies. We're not allergic to the cloud. We're not allergic to working with tech, but it's got to be safe, respectful use of patient data, right? We've had HIPAA for 20 years now, so that we know how to do this in safe, respectful ways, but that's what we got to do. Here's just one example of many working with Google, and this is de-identified data. They know they cannot mix this data with other data sets, but sometimes they have the best deep learning folks, machine learning folks. We're just never going to be able to hire at that level now at UC. And whether it's Google or Apple or Microsoft or any of these companies, we got to do this in safe, respectful ways, but now we can start to predict the future for a patient. In this particular paper, we can now tell if a patient gets admitted, what's the likelihood they're going to pass away or die during that admission. It doesn't mean we can do something about it yet, right? Just because you can tell someone's really sick doesn't mean we can prevent that at all today, right? So we got to put these into clinical trials. Just like any other medication, we're going to have to trial these things to see if they change outcomes, right? But this is one of many that I think you're going to be seeing from the UC system, each campus and then collectively. Now, this is a healthcare-oriented audience, so one of the kind of tricks that I've learned how to move things along faster for us is in population management, right? So we're all trying to figure out, what does population management even mean, right? What do the software tools even mean to manage a population, right, if we're trying to get to accountable care? And the one interesting population I learned, and it's kind of amazing, it's almost like my secret sauce of how these projects could really succeed now. I'm going to give you my secret sauce. Of all the 15 million patients we see, there's one particular set of 100,000 of them that we love even more than all the rest. And those are our employees, right? We're the weirdest of companies that we can deliver healthcare to our own employees, right? You know, Walmart can't, not yet, maybe. Amazon can't, not yet, maybe. Apple can't, for sure. And I don't mean giving Band-Aids like in the first aid clinic, right? But an employee at UC can get care at UC, right? So this is the benefits book we put out every fall, open enrollment. The 2 hours are the HMO and PPO. And we get roughly 100,000 covered lives, right? Some employees and their dependents. And so think about the arrows and the incentives here for this set of folks, right? The rest of the 15 million, we're still mostly in fee-for-service, right? We're moving to ACOs, but we're still fee-for-service. We do something, we get paid for it. But for these patients, everything we do medical-wise is actually a cost center to us, not a revenue center for us, right? So let me make it crystal clear. If one of our docs sees one of our employees and, let's say, generates suboptimal care, generates a really high bill, we promptly pay that bill to ourselves. That is equivalent to burning money on the front lawn of the hospital, right? So now all of a sudden we got one patient subset where amazingly all the arrows are aligned and we can actually move this ahead. And so this is a set that we've been focused on first, are our own employees and dependents. Here's just one example. I got 4 minutes left, I got plenty of time. One example here on brand name versus generic metformin. Okay, so you know metformin is a great drug. We use it first line, type 2 diabetes. It's even usable in kids. but we still have our own doctors writing brand name prescriptions for metformin, brand name metformin, to our own employees. We have the master list now. Okay, we know every patient, we know every doc who's doing this. So for example, Glumetza ER, 500 milligram tablets, internal means it was one of our payroll docs. That claim is costing $3,223. It got refilled 3 times. It should have been switched to the column on the right. That might have been a $4,000 savings. So 4,000, 1,000, 4,000, 5,000, I mean, this adds up to millions right away. You get the idea. And right away, by actually putting eyeballs on this, you can start to see it just drops within 1 quarter. And that's just one drug. And how many more low-hanging fruit drugs are there? I'm not even talking about switching categories yet, right? So that's the future here, is more eyes on this data for operational use and research use as well. I'm going to end with the future, where things are going here. This is the diabetes. Let's focus. I'm going to end with diabetes as well. This is actually what the American Diabetes Association says to treat diabetes with, right? It's nice. This is a national guideline, and it's amazing. We have this guideline for diabetes. In a lot of things in medicine, we don't have a guideline, right? But here's a disease where we have a guideline. It's even pastel colors. It's like made for California. And the way to think about this is you start at the top, and then you go to metformin, and when that fails, you pick one of these 6 other boxes, and when those fail, you add the other 5 boxes, and then when everything fails, you go to metformin and insulin at the bottom there, right? So, you know, like a pachinko machine, have you seen those? The ball starts, you're trying to figure out which way does it go. That is literally this. Which box do our doctors choose right now, right? It doesn't even really tell you which one to choose. And why is this important? Because the boxes are all the same kind of size. Some of these boxes cost 200 times more than some of the other boxes. So what do our docs actually do? So we actually came up with a way to data viz this, starting with UCSF patients, 12,000 patients. We used to call this a diabetes donut, but realized that was inappropriate. So now we call this a lifesaver, okay? And it's a pie chart, and pie is also inappropriate for diabetes. But the kind of way to think about this is you got 1/3 of the patients start on metformin. Well, that's good at UCSF. 1/3 of them start on insulin. Well, that's kind of weird. A smaller starting sulfonylureas. This purple one, they're starting on DPP-4 inhibitors. That's an expensive way to start. That's interesting. And so that's the first choice we make. And we send the patient home, and then they come back in 90 days and figure out what do we do next? Well, that's the next ring. So everyone who was in yellow, they're happy with that first dose. We've seen them back. We've never had to change it again. Yellow to yellow means we changed the dose, same drug. Any other color switch means we added a drug, subtracted a drug, changed a drug here, right? They go home, they come back in 90 days. Here's the next move. They go home, they come back in 90 days, and here's the 4th move. And then you realize we had 1,600 different ways to treat type 2 diabetes. The UCSF, probably too many. Can we get this down to 1,000, 100, maybe 10, 1? I don't know. But can we do comparative effectiveness of the strategies now, not listening to experts to actually figure out what is the right UC way to do this? And by the way, hit one button, we can do this for the entire University of California now. 71,000 patients with diabetes here. So that's the future for us, is to use all this data to improve, to learn what's the right way to do it, and by the way, to figure out really simple, stupid things, like does a drug that costs 100 times more give us 100 times the benefit, right? It's about time we in medicine start to use all this data to actually ask some of those hard questions. And that's what I'm really proud of being able to build with so many others, even in this audience, at the University of California. Thank you.